I'm going to introduce Yazan Massanet, who's going to talk about the oncological safety and technical feasibility of multifocal, multicentric disease. But Yazan, as much as I'd love to introduce him, really requires no introduction. He's a global oncoplastic breast surgeon, diplomat, gentleman, and advocate for education in the universe, let's say. I have known Yazan for many years. He's a delightful person, as you know. If you haven't met him, I'm sure he'd be happy to exchange information and knowledge with you, and his great sense of humor and smile. No further introduction needed.
Thank you for the lovely introduction, Peter. And it's great to be talking in a session that's shared by two of my previous bosses. So it's great to have Michalis, who was my boss in the past, and also Peter, who was my boss in the past.
Almost.
I was summoned to talk about oncological safety and technical feasibility of multifocal, multicentric breast cancer. So I'm one of the surgeons in Aberdeen in Scotland, and I have a few other roles in the UK and outside the UK. I run the iBreast book webinars. The next one is on papers, how to read them, how to write them. The only reason to mention the webinars here, because some of those are sponsored by some of the companies, but there's no conflict of interest and there's nothing to declare here. Now, let's change the talk a bit. Let's talk about multifocal, multicentric breast cancer. Is it time to think again? We're not talking about only oncological safety. There's nothing that can confirm oncological safety, but what I want you to start is thinking about what we're doing for multifocal, multicentric breast cancer, as things have changed significantly. In the past, the days of Halsted, who was the father of breast surgery, really, breast cancer was a locally advanced disease, and the only treatment was surgery. That's why surgery was very aggressive, and that's the classical Halstedian type of incision, up and down, taking pec major, taking pec minor, and that was an aggressive type of surgery. And things have moved significantly now for people to start looking at doing no surgery for some of the exceptional respondents. This is the recent paper by Henry Curer from MD Anderson, was published only last month, and I think Marius Tassoulis and the team in the Marsden is doing some more extra work, which is very similar. Now, to be able to rethink about this, we need to go back to the future. So breast conservation is relatively new. It has been around only in the past 5 decades, and in the time of surgery, that's only a very short period of time. And the RCTs in the past did exclude multifocal, multicentric breast cancer. And we all know about the papers by the Milan study from Veronese and then SABB06 by Fisher. And we have 20-year data that was published nearly 20 years ago in October 2002, both papers in the same New England Journal of Medicine, showing that this is safe. And there's some new data now, looking from cohort studies, mainly from Sweden, looking at safety of breast conservation compared to mastectomy, showing that there is even better survival, even when you correct for many of the confounding factors, but there is lots of bias in those cohort studies anyway. If you look at the data from the past, large tumors were excluded, locally advanced tumors were excluded, central tumors were excluded, and multifocal, multicentric breast cancer was excluded. But why was that? Remember that when they started doing those trials, those people were seeing as people are pushing the boundaries to something that is unsafe at that stage. So oncology was of big doubt, and oncology has changed big time since then. Also, cosmesis was not great, so many of those patients that had the breast conservation did not have great result for unifocal disease with the quadrantectomies. But things have moved on big time. Things from the 1990s to the 2020s. Our radiology is better, our pathology is better, and our oncology is far more superior now. And we have the oncoplastic tools and techniques to use to improve the outcomes. And if you look at those exclusions, so most of the RCTs looked at tumors up to 3 centimeters, some of them up to 4 centimeters, some of them up to 5 centimeters. But now we're quite happy to excise things that are much bigger. If you look at this paper from Krishna Kloff, published 7 years ago, and if you look at that, they were taking out tumors up to 16 centimeters with level 2 oncoplastic surgeries. And the term extreme oncoplastic surgery came from Melvin Silverstein, and that's mainly talking about T3 tumors, multifocal, multicentric tumors with good excision rate, with low local recurrence rate. So without RCTs, we know also the big tumors, and multifocal multicentric tumors are excisable with good outcome. And nearly all units will have patients like this. This is a patient with an 8 centimeter phylloides that was borderline. That's her post-op. And I always show this because this is the first lady that I've done as a consultant with an 8 centimeter DCIS and completely excised. She's well doing okay. And central tumors in the past, everybody had a mastectomy, but for no good reason. You still can get good aesthetic outcome with central wide local excisions, even with mammoplasties, where you can remove the nipple. It makes your mammoplasty much easier, or with a Grisotti flap. So we already decided that we don't need to exclude those patients, and locally advanced tumors are completely different cohort. It never made sense to me why you can excise a large area of DCIS, but if you have two smaller areas that can be excised in the same excision pattern, you need a mastectomy. So if you have a 5 centimeter tumor, you are okay to do a big mammoplasty, but if you fragment that 5 centimeter tumor to 1.5 centimeter tumors, with a 2 centimeter in between, you need the mastectomy. It does not make sense. It's the same excision. So we started looking at multifocal multicentric breast cancer, looked at what's there in the literature, is oncology different, and will surgery make any difference? So when we came out with this paper, and it's great to see Amit, he's sitting with us today, and it's great to see Michalis also, who were both authors on that paper. In general, we accept that people are innocent until proven guilty, but in certain circumstances, we're labeling people as guilty until proven innocent, and that's what we have done with multifocal multicentric disease. For large tumors and central tumors, we have already made up our mind without any RCTs that it's safe to do this. But for multifocal multicentric, we've made up our mind that it's not safe to do this. And if you look at the data, there are 3 widely cited papers. This is not to criticize the papers. This was good. Those were good papers 40 years ago, but that's 40 years ago. So if you look at the papers, this one was by Leopold from Harvard, and what they've done is they looked at multifocal multicentric breast cancer. The recurrence rate was 40% compared to 10% with unifocal disease, but that was based on only about 10 patients. So you will not make all your decisions based on a paper with 10 patients. The second one was slightly bigger. It was by Kurtz, and they had 60 patients, so it's not much bigger. The local recurrence rate was 25% for multifocal multicentric compared to 10% for unifocal disease. But here, if you read the paper, only one patient had negative excision margins. Remember, when they used to do wide local excisions in the past, used to have a grossly excise the tumor, and did not look at the margins under the microscope every time. So that's something relatively new. So this is something that came from the 80s and 90s, and that was not all assessed. So only one patient had negative resection margins, which is something that we would not accept now. And the third one by Wilson, also a small cohort of 13 papers, so 13 patients. So you would not change your practice based on that if you read those papers now. And as I said, everything has moved on. Radiology is better, oncology is better, chemotherapy, radiotherapy is better, and I hope that us as surgeons are also better. Our techniques are completely different. Let's start with the pathologists. So many pathologists will not like this slide when they see it. So there's lots of papers if you look at the pathology. The main one is to look at this paper from Holland, and they all talk about the same thing. This is from the 80s. So they looked at 400 mastectomies. When they got the mastectomies, they reviewed the images and the clinical notes, and they thought, which one of those are suitable for breast conservation? They found that about 280 of those are suitable for breast conservation. So if they had conservation, would they had really unifocal disease? Because they thought that all those mastectomies were done for unifocal disease. They've done further assessment on the pathologies. They found that only 37% were truly unifocal. And they found that only 43% of the ones that had multifocality was within 2 centimeters. More than 50% the multifocality was more than 2 centimeters away. And that's why we need radiotherapy. Otherwise, if you know that the tumor is out, you don't need that radiotherapy. These will be picked up better now on images. That means that our conservation rate might go down. But what about the outcomes? Are they better, irrespective of surgery, for multifocal multicentric compared to unifocal or not? And there's not many studies. So this is the Brenda cohort study, nearly 9,000 patients from Germany. It's a great study. So they looked at unifocal disease. There was about 7,000 patients. Multifocal disease, 1,400 patients, and multicentric, 400. And you can see that unifocal did better for the recurrence-free survival. Slightly multifocal did better for the overall survival, which did not make sense. But most of the tumors were larger tumors, more likely to be node positive, more likely to be higher grade, and more likely to be younger patients. And when you correct for all those things, survival is not different at all for all unifocal, multifocal, and multicentric, for recurrence-free and overall survival. So the biology is the king. It's not the actual, not the fact that there's more than one focus. And when you look at patients that had chemotherapy up front, and this is a paper from MD Anderson looking at neoadjuvant chemotherapy patients, there was about 900 patients in that, and multifocality did not affect local regional recurrence, disease-free survival, or overall survival, that irrespective of surgery. And the similar cohort from Lynch from the States that showed the same, that multifocality is not an independent factor for local recurrence, overall survival, or disease-free survival. And we summarize that in our paper in this little table. And when we sit in the MDT, that's what we make the decision. We make the decision on the bigger tumor. We don't make the decision on the fact that there is more than one tumor. We ignore all the smaller tumors. So will the type of surgery make any difference then? And that's, we need to look at cohorts that had a look at a mastectomy versus breast conservation. And still many ladies will need a mastectomy. I'm not saying that everybody can have a conservation for multifocal, multicentric. It's only a cohort of patients that can. Let's go to the city of light. So Krishna Kloth has changed many things in oncoplastic surgery and breast surgery. And one of his, I think, key papers is this paper published in 1999. They looked at their cohort that looked at multifocal, multicentric breast cancers, and they've been conserving them since the 90s. 56 had breast conservation, 132 had mastectomies. Recurrence rate and survival rate with 10-year follow-up was similar. Then Kaplan had a small cohort of only about 50 patients. 32 had breast conservation, or 36, compared to 19 that had mastectomy. Also, there is no difference in the local recurrence and survival. And then when you go to Milan, you can see that they have matched 100 cases that had oncoplastic breast surgery for multifocal, multicentric disease, match them to 100 cases of mastectomy. Local recurrence was slightly higher in the oncoplastic breast surgery. Regional disease was much higher, is slightly higher than in the mastectomy, but that was not statistically different. And if you go back to the Brenda study, they looked at the cohort that had breast conservation surgery versus mastectomy for multifocal, multicentric disease. In fact, if you look at that, there is no difference. There's no significant difference between conservation and mastectomy. In fact, if you look at it, there's a trend for the conservation to do slightly better, but that's only a trend that is not different. So there is also lots in the literature of cohorts of people that did not have any comparator. So this is from Milan again. They looked at patients that had breast conservation for 2 tumors, 3 tumors, 4 or more tumors, and in their cohort, the 5-year local recurrence rate was only 5%. So, but this is selected cohort of patients. Similar story from Japan, and there's the feasibility study, the Z11102 by Judy Bouty, that shows that it is feasible, it is doable, as long as you plan it well. And you can get away with it for more than 80–90% of patients. This is a systematic review by Zoe Winters, and that was done mainly to plan for the Miami study, which we'll come to, looking at breast conservation in multiple ipsilateral breast cancers. Nearly 3,500 ladies and 17 studies. The conclusion was underpowered, historic papers, no oncoplastic breast surgery, limited follow-up with bias towards breast conservation for the better prognosis, low-risk patients. But that's all what we know. And we know that there will be bias. There was the conclusion that we need an RCT, but also in that paper, there was nothing to say that they will do worse. And that's our summary in our paper, which we will not go through. So if you look at all the evidence, there is really no evidence that outcome is different. And there is no evidence that keeping the breast is going to affect that outcome. And that's the key thing here. So absence of evidence isn't evidence of absence. And if you look at what is being done, I think there's many people talk about levels of evidence and RCTs, and everything should be done by RCTs. We're surgeons. We have very rarely RCTs in surgery. So the RCT that was being planned was the Miami study. They tried to randomize between breast conservation and mastectomy for multifocal or multiple ipsilateral breast cancers. And guess what? After 2 or 3 years' time, they closed because they did not recruit more than 5 patients, I think. Nobody, if you can't conserve the breast, the patient, if you tell the patient, I might be able to conserve the breast, let's flip a coin and see if you will keep the breast or not. Most patients will say no. If they want conservation, they will go for the conservation. And the other study that is looking at that, but it's only a cohort prospective study, is the Anthem study. It's not looking at only multifocal, multicentric. It's all looking at all extreme oncoplastic surgery. Still years to come. We need to understand what people are doing because sometimes little fish don't know they swim in a barrel, and that's sometimes what's happened in certain units in the UK. They keep on doing the same thing and the same thing again. The webinars were an eye-opener, especially for surgeons that come from South America. Many of their mammoplasties that they were showing online were for multifocal multicentric disease. So we thought that let's run a survey. Let's look what people are doing across the world. So we've done the MINIM survey, which looked at global variation in how people manage multifocal multicentric breast cancer. We had, from more than 100 countries, 750 participants. Nearly 90% are breast surgeons. There's some oncologists, some plastic surgeons, there's some gynecologists. And 65%, or 2/3, were experienced, more than 5 years experience, and nearly 50% in big centers, more than 200 cancers. And the gist of things is that nearly 70%, if they knew it's multifocal, multicentric breast cancer, would attempt conservation, especially for multifocal disease. Nearly 70%, if they had known that it was a unifocal disease but found a satellite, it's completely excised, they'll be happy with that. Very small percentage will go for a completion mastectomy. Nearly 2/3, if the satellite was a centimeter or 2 away, which is a multifocal disease, they will still be happy. And very small percentage will go for a mastectomy if the satellite was involving the margin. They will still go for re-excision. So most people are comfortable to conserve breasts, at least on surveys, but you don't see that in the MDTs. Many people in the MDTs shy away and say, no, we need a mastectomy. It's key to know that we need to do receptors on all tumors because sometimes they might have different biologies, and it's key to know that 2/3 said that they will do the assessment in the MDT based on the more biologically aggressive tumor, which is the correct thing because sometimes the bigger tumor is not the more aggressive tumor if you have multicentric disease. The disappointing thing is that nearly 2/3 did not discuss that with the oncologist because you might need to boost 2 places, and there's recent papers suggesting that boosting 2 areas is feasible and is doable. But if you do the beautiful mammoplasty, excise the tumors out, and your oncologist come and say, I cannot give the radiotherapy based on what you excised, then you might end up going back and doing a mastectomy. So you need really a multidisciplinary approach for this. How to do it? We're going to be very brief in this because I have only 3 minutes, and Michael and Peter will kill me. So there's 2 key papers. If you want to do oncoplastic surgery, the main key paper is the Macaulay and Macmillan paper about mammoplasty, is the one on the left-hand side. It talks about primary pedicles, extended primary pedicles, and secondary pedicles. And we're not going to go through the atlas of oncoplastic breast surgery because that's something that everybody has read. Now the principles is keep it simple. And if you can plan a mammoplasty and excise the 2 tumors or the 3 tumors in the same usual excision pattern, that's great. If you can't and you need to do extended pedicles or secondary pedicles, try to use the shortest pedicles. You're less likely to get in trouble. Always when you start, epithelize everything and keep all the options open. And if there's no options to excise it in the normal excision pattern, then you start looking for extended primary or secondary pedicles, and don't go for a very long pedicle. If you can do 2 shorter pedicles, it's much safer. And I stole that from Peter in one of his talks a few months ago. And think, is it worth doing? Will a mastectomy and reconstruction give a better outcome or not? If you think that you can do a mammoplasty, it's not going to look good, then you go for a mastectomy and reconstruction. And you need to think, can you do it with replacement or displacement techniques? And we have a lovely session about chest wall perforator flaps. Just quickly through those slides. So if you're doing a superior medial pedicle, that's your usual excision pattern, and that's your usual excision pattern roughly for the inferior pedicle. So if you have two tumors in the lower part of the breast, you can easily take them with the inferior superior medial pedicle. If it's a small breast, you can do a chest wall perforator flap from an eye cap and lift it and croissant that and to cover both defects. And if they're in the same other outer quadrant, you still can do the same. While if they're on the upper half of the breast, it might be better to do an inferior pedicle, and in the small breast, you can do a chest wall perforator flap and resurface all that, which is not that difficult to do once you get used to it. And look at where are the different tumors, and then you can plan your different pedicles based on those two pedicles. And what to do? What I usually do is, remember, this is not for everybody. It's selected cohort of patients when it's technically doable, and please be careful. Extensive DCIS, non-calcified DCIS, lobular malignancy, those are the ones that usually catch you and they'll end up not getting the tumors out. And remember, the biology, always challenge the biology. So if people are trying to avoid surgery in excellent responders, if you have a HER2 positive tumor or a triple negative tumor, give them chemotherapy up front. If you respond well, then you do the conservation. If they don't respond well, you don't venture there. You do a mastectomy. Tell the patient that this is not the usual standard protocol. That's what I usually tell them. And I always do MRI scans to decrease the surprises. And I always talk to my oncologist first. And remember, you're doing this for the patient, not for your ego, because some people want to do this just to say, I've done this. So the real question is, why isn't breast conservation an option? And thank you.
Wonderful talk. I'm sure everyone agrees. We'll take a couple of questions now because this topic's a bit different. Any burning questions from the audience? We will have questions also at the end of the session. Yes.
Thank you for your excellent presentation. I really enjoyed it. First of all, we have to start from the definition of multicentric. Yes. It's quite different in the most papers. Finally, I think that multicentric disease is the disease that someone cannot remove it macroscopically all. Everything that can remove macroscopically all is not a problem for a oncoplastic surgeon. Thank you for excellent presentation.
Thank you. And yes, that was one of the things that we talked about in the paper and on the survey. What is the definition of multifocal? What is the definition of multicentric? And many people are shying away from that. They're using the multiple ipsilateral breast cancers definition. So there's more than one tumor. As long as you can get them out, that's fine. In principle, multifocal is the same pathology in the same area. Some people define it within 2 centimeters. Some people define it within 5 centimeters. Multicentric, it's usually you see that the pathology is slightly different. This is a grade 2, this is a grade 3. The receptors are slightly different. So multiple pathologies like synchronous tumors happening in the same breast. Well, I don't think we'll get anybody to agree on what's the definitions, and that's why people are starting to shy away and go to the multiple ipsilateral breast cancer definitions.
Great, thanks. Any other questions? Yes, please.
Thank you very much for this. It was very, I really liked it. I'd like to ask you, often in multicentric tumors, if you have ERPR positive tumors, you have some underlying pathology in the breast. Perhaps you have an LCIS, or you have multiple TPS, or you have DCIS. So it's not only the sites, the foci you have to excise because you have an invasive cancer. The thing is what you leave back. So how much does this weigh on your decision, or how much did it weigh in these studies?
Well, if you have biopsies that show that those are discrete lesions and there's no other pathologies and there's not much DCIS, or the DCIS is seen on the images, there's no problem taking them out. But if you see multiple areas with atypical intraductal AIDPH, or you find that there is an invasive here and there is a B3 here and there is a B3, and there's big areas of changes in the breast, then you will lean more towards a mastectomy. As I said, it's not for everybody.
Multicentric disease to do perhaps genetic control before you take this decision? Because, as I understand it, it shows something for the breast if you have.
The genetics, that's not multifocality or multicentricity, I don't think it's part of the genetics testing, but bilaterality is part of the genetic testing.
Yeah.
So that's something to never crossed my mind, in all honesty. But for example, anybody below the age of 40 that has breast cancer will have genetic testing. Any triple negative will have genetic testing. So there is lots of their patients will have genetic testing. And genetic testing, BRCA positives are slightly different, completely different cohort of that. But are you aware of any multifocality being a trigger for testing? We usually mainly use bilaterality rather than multifocality.
That's a good question. I think anecdotally we see that, don't we?
Yeah.
Probably we all have some cases like that. That's great. Is that okay?
Thank you.
Michalis has one question, so over to you.
So the answer is not yet.
Yes.
We know that multicentral disease is associated with usually more foci in different quadrants or greater risk of local relapse in the future, etc. But at the moment, no.
Because multicentrality in theater, it's synchronous tumors. It's more than tumor happening at the same time.
It is.
So it makes sense to check for the genetics, but I don't think it's part of the guidelines till now.
My question is, would you ever consider doing 2 lumpectomies in cases where the foci is far from each other? Small foci, big breast, really tempting. Come on, let's remove this, let's remove that, and keep the breast.
Even when we did the paper, if you remember, we had lots of discussion about that, and I try to, if possible, to excise everything on block, because you don't know what's happening in between, especially there are similar pathologies. It's very, very rare that I've done two simple lumpectomies, but you'll be always a bit more nervous about that for no good reason. Leeds have been doing this since I was doing my research degree 20 years ago, and Leeds were doing multiple lumpectomies. They haven't published their data, but their local recurrence rate is not high. And I think Edinburgh has been doing this for a while, but I don't think that anybody has collected their data for publication. And that's the issue, is that there is not much published in the literature.
I think there was a discussion in St. Gallen in the recent years, am I wrong? They were asked whether surgeons would do 2 lumpectomies in but we'll see.
Can we have a poll from the audience? Who would do 2 lumpectomies if 2 tumors are diametrically opposite? So, yeah, a minority, but significant minority.
Dynamic minority.
Yes, a dynamic. All right, we might move on then. Thanks very much again, Yazan. I think that's a great session, or start of the session. We're going to now hear about BIA-ALCL, a hot topic that continues to be hot. Michalis, you're going to...
So I would like to invite Dimitris Mastorakos to the podium. Dimitris Mastorakos is a plastic surgeon in Mitera Hospital, and he knows this field very well. He has been doing reconstructions for many years, and we are all ears.
Thanks for the invitation. I suspect for the benefit of our gracious guests, we're going to be talking in English, aren't we? So I was given the opportunity to talk about this joyless and rather sobering subject of ALCL. So we're going to be going over history, epidemiology, staging, theories, how do we handle it, and we're going to be talking about the squamous cell of the breast and the B-cell lymphoma as well. So this is the first case reported in the literature, PRS 1997. You see that there was an augmentation mammoplasty. Unfortunately, this was not paid enough attention at the time. The lady was treated with chemo and radiation and did well. Unfortunately, I don't know her follow-up, but you can see the whole thing resolved without surgery. So this is its history. FDA makes the first report back in 2010, all the way down to biocell textured surfaces being recalled 2019, and just last September, the FDA put out a report about the breast implant-associated squamous cell carcinoma of the breast. And unfortunately, we're seeing some rather ominous changes. There's a new ISDN code for this, and insurance companies in the US are starting refusing treatment for women that have lymphoma just because they have had the otherwise indolent breast augmentation. And this is the situation here. And at this point, you see that there is one case reported in Greece, and you can see a vast difference in terms of reporting throughout the world. It's obvious that we need registries. It's obvious that one that deals with this disease should report it somewhere. You can see that we're talking about 1,300 cases and about 35, I think the deaths now are up to 60. So the challenges to study ALCL are the first, there's very few cases, and there's a very different frequency depending on the texture used. And also there's a very great delay between the implantation to the development of the disease. There's no validated in vivo models. Patients don't necessarily follow up with their original surgeon, and there are missed or delayed diagnoses. Causes are mostly bacteria, particulates, silicon autoimmunity, viruses, and a genetic predisposition. And out of the NCCN, we see that the definition is more than a year from the implantation, with the average 7 to 9 years, a mass, regional lymphadenopathy, or overlying skin rash, or even capsular contracture. Apparently, not singly capsular contracture has ever been diagnosed as ALCL, but this is something to consider. Tumor cells are CD30 positive, ALK negative. They have large anaplastic morphology, and they demonstrate the T cell clone. All these four need to be present to diagnose ALCL. And in order to help with this diagnosis, the first step is always to aspirate a minimum of 50 cc's to help our pathology colleagues of the fluid if the presentation is with a significant amount of fluid. And this is how it's done. Under guidance of ultrasound, this is the way that the fluid would look like. This is a benign seroma that you can see some cells positive for CD30, and this is ALCL. You see the many more cases and many more cells positive for CD30 and the monoclonality of the T cells. How do we treat it? Ultrasound of breast, again, MRI in selected cases, FNA biopsy, and we check for all these things. As we will see down the line, we need to check now for CD5, CD6, and cytokeratin because we need to rule out squamous cell as well. Pardon me? Yep. And this is its staging. As you can see, most of the cases have to do with the infiltration of the capsule. And we see the T1 through T4, how the cells are invading the capsule and eventually through the capsule and on to the original lymph nodes and metastasizing. This is where the things are getting a little tricky. As you see that the idea for us is to excise the whole capsule if possible and together with the rest of the disease. Only if this is not possible would we consider other things such as radiotherapy and of course chemo if there's metastasis. The FDA recommends that all cases should be reported to their profile registry, and keep in mind that on 4.6% of the cases there's evidence of the LCL on the other side, so usually this would be handled together. And this is how this should be done. Try to remove the whole thing in one go together with the capsule and the implant. Even though it is under the pec major, we still need to peel it off from the chest wall. Apparently, there's no evidence that if this fluid is spilled, the prognosis of the patient is worse, but it's probably a good idea to not spill the fluid. What else? This is the NCCN guidelines of 2023, basically the same things. And this is the chemo regimen. Brentuximab seems to be working very well, so one of the most popular regimens at this point are CHOP and Brentuximab, which is an antibody against the CD30 associated with a toxin. And keep in mind that Nearly 80% of the women with ALCL will present with a seroma, and of course the prognosis is significantly better if they are handled early, but also that there are CD30 positive cells in benign seromas as well. And this is how it looks on MRI. You see that this is a tiny focus in this capsule. This is a lymph node of an synchronous lung cancer, so don't pay attention to this. But you can see here a stage 2 lesion with a significant extension outside of the capsule. And this is the scan, and this is the intra-op photo. Again, this is what we're looking for, a seroma with anaplastic cells, CD30 positive and monoclonal. If there's a few CD30 cells, this is not enough. So apparently, it seems that it might be, at least in the early stage, in the stage 1A, this is more like a lymphoproliferative disease, such as that this could potentially become an invasive lymphoma. It's not yet possible to determine the progression of stage 1A, which means that we can't just follow these ladies up and see if they heal by themselves, because the only way to make sure that this is 1A is to biopsy throughout the capsule. And Dr. Clements, who's Mr. ALCL, suggests that we should take 12 biopsies throughout the capsule, which means that if we want to diagnose it, we need to remove the whole capsule, which means that we will never know if some of these cases may go on to have an indolent course and heal by themselves. So this may be the reason why we have these huge discrepancies between cases throughout the world, and you have physicians like Peter Cordero, who is following very closely his patients and reports frequency down to 1 to 100 women. Again, all these ladies with BIA-LCL could have a progression of the disease, lymph node involvement, and death as a result of the disease. So why are bacteria relevant? Because breasts are clean, contaminated surgical sites. Breast implants are chronically contaminated. BIA-LCL apparently is shown in much more in textured devices, much more in macro textured, but also in micro textured as well. Bacteria do cause certain malignancies, and Ralstonia piquetiae has been associated with this. And we see that breast is a clean contaminated site, sometimes more contaminated with a greater diversity of bacteria compared to the skin. And as we said about Ralstonia and being associated with ALCL. There's this very significant paper in the plastic surgery literature about these 42,000 cases following a particular protocol for implantation, basically to try to be as sterile as possible, and with no cases of ALCL. Clearly, this makes a significant difference, but apparently the research is pointing now to hypoxia. It seems that genes associated with hypoxia are being upregulated in the capsule of ALCL. Tribology, which is basically studying the effects of friction between surfaces, genomics, and the immune function of the patient. So we see that molecular profiling reveals, as we said, a hypoxia signature in breast implant associated lymphomas. Silicone implant cell surface roughness will increase contact pressures, will increase frictional shear, will create more debris production, and that would increase inflammation and increase cell death. What else? Implant texture has been shown in this Korean study, which has taken a lot of heat to fare worse in the case of women with breast cancer. We don't really know why, but apparently textured implants are seeming to be creating more of an inflammation with higher CRPs and whatnot. So this is something to keep in mind. We also see that women with breast implants have a higher percentage of antibodies against gamma-globin and MUC1, and this is one attempt to explain why women with breast implants seem to have lower rates of breast cancer compared to other women, even if corrected for other issues such as BMI and stuff. Now, out of Dr. Clements, again, this is our full spectrum, ALCL with textured implants, JAK-STAT mutations, P53 mutations. We have textured implants and plus minus Epstein-Barr virus infection. This could give us a B-cell lymphoma at the breast. Chronic irritation with depressed immune response. This could give us the squamous cell. Apparently, we have this privileged area between the capsule and the implant, which has hypoxia, and chances are is immunocompromised. And this seems to be the reason why these things are developing. Some of the recent studies show that, am I going back? Yes. That roughness of implants in the vicinity of 4 microns, which would put them in a smooth to nanotextured implants, seem to be creating the least inflammation and foreign body response. And we see here that the data for the ALCL is very, very dirty. You see that, for example, 26% don't have a mention of what kind of implant surface. 61% have not been assessed for ALK, which is usually negative for this type of lymphoma. 47% out of the death cases are not mentioning the implant surface. 78% again don't have ALK status, and 41% of the death cases don't report the manufacturer. It would be very tempting to think that there's a difference between the women that have ALCL and the women that die of it. Again, this is a paper out of Duke that mentions the reported in the literature, the cases reported in the literature. Some of the things that clearly stand out are the textured implant 100% incidence, which makes me at least to stop using textured implants, or at least the macro and micro. Allergan, of course, has a significant percentage of 80%. Unblocked capsulectomy is what is being done mostly. Confined to the capsule, 73%. And we see that in most cases, surgery will be the only thing needed, and the cases will be handled by that. In advanced disease, we would add chemo as well as radiotherapy. And recurrence, unfortunately, most of the time is in the form of a mass and with not very good outcomes. And this is the algorithm that has been proposed for the handling of such cases. This is a good idea to read this paper of Mark Clements from the PRS in 2018. I have seen that you are very familiar with PRS anyway. So squamous cell carcinoma, this is an epithelially based tumor, sheets of squamous cells, exhibits highly invasive properties. This is a totally different animal. You can see how this is infiltrating into the chest wall. This is its clinical presentation. This is a week after the implants were taken out, when the surgeons realized that they couldn't take the whole thing. This woman would end up needing a chest wall resection. This has been reported, about 24 cases have been reported dental implants, and there are also reports for orthopedic implants. Epithelially based tumors, sheets of squamous cells, highly invasive properties, tissue markers CD56 and P63, so we need to assess for those, and flow cytometry with squamous cells. Average presentation 56, much later than the ALCL, 20 years since implantation. There's 16 cases so far. They've been up to 20 as far as I understand. Mass and tumor, extracapsular spread, 75% at the time of surgery. And they're ER/PR HER2 negative. Most of the time they are thought of as a breast recurrence in the first time of presentation. And this is basically what we should be looking at: CD30 ALK, CK56, P63, and flow cytometry. What's the, I'm finishing up. The theory is it would be either a marginal lens ulcer, contamination by skin, or duct cells, most probably marginal lens ulcer. Again, this is the one thing that you should keep. 43% lived an average of 6 months, compared to 22.8 for the ALCL. And the BCL, which is, again, another another much rarer, and it has to do with Epstein-Barr virus and the NCCN. So we are obviously having to struggle some more together with our patients with some more snakes. Thank you very much.
Thank you. Lovely talk and lovely talk, and it's good to learn the latest facts and figures. So a lovely update. Thank you for that. Any questions about that talk? Yes.
Thank you, Mr. Mastorakos, for this very nice presentation. I think this raises a really important question, which we all hear about the last few years, but it's very hard to decide what we do. I mean, is it right to say at this point that the evidence is there? Okay, there is a malignancy related to breast implants, and in our practice, it's about patients that already had breast cancer. Okay, so is it right to say that we should be abandoning the textured implants while waiting for more clear evidence at this stage, or should we, on the other hand, explain to the patients that you have a chance of having 1 in 300,000, 1 in 3,000, 1 in 300, according to some series, chance of developing this ALCL. So, because in all the occasions where I talk to patients, breast cancer patients, about the chance of developing a malignant lymphoma from the implants, the patients refuse to have textured implants. So, what is our position right now?
Okay. Thanks for this question. Well, personally, I have given up textured implants. I'm using nano or smooth, and unfortunately, since smooth seems to have a higher rupture rate at the point, I'm veering towards nano at this point. There's really, after fat grafting, there's really not many significant benefits of using textured implants, because you can imitate the anatomical shape, which is basically the only difference between textured and smooth, using fat grafting. So I think by adapting our techniques, we can still give a good result to most women. Now, in augmentation, this is a different story, because in augmentation with severely deformed breasts, you might want to still have textured implants, but there are nano-textured anatomical implants still. Thank you.
Thank you. We might continue on now.
Just one question.
Yes, one question, Michalis.
Yannis, do you know what authority we should report if we find this anaplastic large cell lymphoma? Is there any official authority we should report the case to?
I think the main database is the profile database of the FDA. They are doing the most serious work as far as ALCL. I'm not sure of a European-based registry as of yet. Unfortunately, as you are aware, I'm sure, we have a very hard time figuring out how many implants are used, what make is being used, which country they're being used. So we really do not have any idea of the denominator. But I think we should report it, and the Americans are probably doing it the best way as far as I know.
So no national authority, no national registry on that?
Well, our association does collect them, yeah.
So National Society of Plastic Surgery.
Mm-hmm. There you go.
Thank you.
Thank you. So we'll continue on with the next speaker, and he's going to talk to us about flaps versus implant selection for reconstruction.
So we're calling to the podium Dr. Yannis Giannas, who is a plastic surgeon at Euroclinic Hospital here in Athens.
Good morning, everybody. Thank you for the invitation to the organizing committee. As a plastic surgeon, I was given the task to talk about flaps and implants and how to choose the right patient. This is a really big area of breast reconstruction. It's effectively the whole breast reconstruction. So I'll try to be as concise and brief as possible. I have no disclosures. And as we probably all know, the options for breast reconstruction relate to the use of alloplastic materials as tissue expander and implants, plus or minus dermal substitutes or other type of scaffolds as tie loop. We have autologous reconstruction with various flaps and a combination of flap and implant as the latissimus dorsi. No procedure outshines the other in all circumstances. However, certain patients clearly benefit from careful procedural selection. Depending which author you read, which article you read, there are reports of similar satisfaction, and at the end, the overall plan for reconstruction must be an open dialogue between patient and surgeon, one that ultimately involves listening and education. It is important that the surgeon is familiar with all the type of reconstructions, and depends on the hospital resources, and at the end, the most important thing is the patient wishes. Implant-based breast reconstruction currently represents the most prevalent form of breast reconstruction, reflects the increasing number of bilateral cases of mastectomy, and the fact that there are necessary greater resource requirements in autologous, especially microsurgical reconstruction, who has financial implication. In the US, roughly, there's about 70% implant-based reconstruction. In Europe, I would say it's a little bit less, the implant-based reconstruction, a little bit more flaps. And what do we do? One or two stages? Two stages, the traditional alloplastic reconstruction, which involves the placement of a tissue expander, temporary tissue expander in a total submuscular plane, alternatively a partial submuscular plane with a scaffold support, and tissue expander should not be placed in the prepectoral level. One stage reconstruction with an implant placed at the subpectoral, prepectoral level with a scaffold to cover the implant completely. I think there are talks afterwards that discuss the advantages and disadvantages. And just a schematic representation on the left, you can see the serratus anterior, the pec major, the tissue expander, and the lower, the anterior fascia of the rectus muscle. And on the right, the scaffold, which could be the alloderm or biological, or tie loop or any other type, Galaflex, that we use to cover the lower part of the implant. Two-stage implant is a safer option, gives a controlled result. You do it in 2 operations. Overall complication rate is relatively low, and the usual complication, which involves mastectomy, flap necrosis, infection with a low rate, seroma or hematoma. And young woman with a 2-stage reconstruction, tissue expander, and implant. It's about a year after her reconstruction, gives a nice result with very low risk of complication. One stage, at the beginning of the last decade, there were several reports starting to use the 1-stage reconstruction, and we had higher rate of complication. Over the last few years, we have comparable results as we learn to use to make use of the scaffold in a better way, and now we have comparable results of complications, and it is cost-effective. So even in a large ptotic breast, as this woman, you can do bilateral mastectomies with 1-stage reconstruction, and you complete it with a tattooing or a nipple reconstruction at a later stage. And that was one of the problems initially. What do you do with a large ptotic breast? You can do it even in a large ptotic breast. This woman was a large ptotic breast, bilateral mastectomies, nipple preserving, and that is her result after about 4 months after her operation, which gives a nice stable result. A younger woman with tubular breast, ptotic. Despite that, she had bilateral mastectomies, nipple preservation, and you see the result on the lower part here. Unilateral cases are a bit more difficult because you find it's difficult sometimes to reproduce the ptosis or the pliability of the contralateral breast. This is a week after her operation, 1 stage. And you can see still has the drains, and then at about a year afterwards, she has this sort of result. with an inframammary fold incision. There are limitations with the tissue expander, which relate to the capsular contracture, implant failure, problems, limitation with the aesthetic results, especially in unilateral cases. Very difficult to match the ptosis and pliability, as you saw earlier in some of the cases. Tissue expander in the implant is placed in the submuscular position that can lead to a vertical discrepancy with a fairly fixed superiorly displaced breast mount in comparison to the ptotic native side. And also sometimes you have the problems, the lack of an available skin envelope for tension-free coverage. And you see this woman, it's a young woman, about 40 years old. She has, on the left breast, an aggressive tumor, which required mastectomy. And she had, on the right side, prophylactic mastectomy with nipple preservation on the right side. On the left, the nipple obviously was removed with some skin. And you see one-stage reconstruction on the right. On the left, she had two-stage reconstruction with an implant, with a tissue expander and an implant, and then she had radiotherapy. The timing of reconstruction. Immediate reconstruction is generally preferable. More pliable skin envelope and a native inframammary fold helps a lot for the cosmetic result of the reconstruction. Fewer operation, and the patient may feel less debilitated following the mastectomy. Delayed reconstruction with tissue expander is possible, but there's a lack of pliability, is more painful, result in less supple, less ptotic finished product. For one-stage alloplastic reconstruction, we'll put the implant either subpectoral and cover the lower pole with alloderm, Galaflex, or tie loop, or prepectoral and cover the implant with a scaffold. And both covers, both muscle or scaffold, are the standard of care in implant-based reconstruction. Scaffold has a distinct advantage as a better lower pole projection, better IMF control, and reduced capsular contracture. However, there is a variable increased risk of complication, and the cost is bigger. And the scaffold has become very popular with NAC sparing mastectomy and one-stage breast reconstruction. Implants, smooth or textured. I think my colleague Dimitris touched a little bit on his talk earlier. At the moment, the situation is the smooth implants remain, smooth round implants remain the most popular option in the US, as they feel softer and there is no risk of anaplastic large cell lymphoma. In Europe and the UK, textured anatomic fill firmer, and we use more of the textured anatomic fill implant, as they feel firmer but give a more natural shape and result. All options should be discussed with the patient. And several papers show similar rates of satisfaction 2 years post-op, with more those secondary adjustments with round implants. And you need to do always fat grafting. I still use textured implants, by the way. And which device should be irradiated? No device should be irradiated if possible. Radiation therapy has a lot of risks, significant risks, and it causes a lot of problems on the reconstruction. It's a major challenge for us. Increases the risk of complication. There are papers that say that's about 4 times the risk of complication. And most common complications are infection, capsular contracture, and mastectomy flap necrosis. When do we irradiate? The timing is still, the jury is out, and there's a lot of debate about that. In any case, you should have good communication between the radiologist and the oncologist about the timing of the radiation, the deflation of the implant. There are different strategies, and these strategies have compared in the past and demonstrated that reconstruction receiving radiotherapy to tissue expander had greater rates of reconstructive failure, but higher surgeon-rated scores of aesthetic outcomes. Patients reported similar outcomes. So we're not really sure if we should continue to irradiate the tissue expander or do the exchange and irradiate the implant. Overall, the post-mastectomy radiation therapy universally appears to increase complications, and there are unique advantages and disadvantages regarding the timing and should be discussed with the patient. Patient having one-stage reconstruction should be advised that the result may mirror those undergoing radiotherapy of the implant after 2-stage reconstruction. So they should consider flap reconstruction after irradiation. New techniques in radiation as prone position may help limit the collateral damage and mitigate the effects. Another strategy is after irradiation with tissue expander in place, instead of exchange to implant, reconstruction with a flap is significantly better, and there's decreased risk of failure and there's no increased risk of capsular contractions. And options may be either LD flap or an implant or a DEP flap. And so 2 weeks after the radiation therapy, we reinflate the tissue expander, and about 3 to 4 months after the end of the radiation therapy, we can proceed to the different types of breast reconstruction. I put this slide up to show you the difference, the challenges we have. This is a woman that's had bilateral mastectomies. On the right side, she had nipple preservation and immediate reconstruction with 1 stage. On the left, the breast surgeon had to remove part of her lower pole skin, the nipple, and part of the pectoralis major. So I put a tissue expander with a scaffold to expand her. She had radiotherapy, and you see the challenges you have. She started pulling up the implant on the left side. For personal reasons, the patient delayed to come for exchange of implant or proceed to the next stage, so developed capsular contracture. Then I exchanged the implant because she didn't want flap reconstruction, which I think is the right thing to do in her case. And although I use the same size of implant, you end up with a smaller breast with the problems that we discussed earlier. And she's waiting for fat grafting, and I think at some stage probably she will need a flap reconstruction. So flaps, age is not a predictor for poor outcome, so any woman should be offered flap reconstruction if she wishes. Even women more than 65 and above, there's no problem to proceed to autologous reconstruction. And in fact, may be particularly beneficial for the older patient, given that these patients generally present with ptotic breast and abdominal laxity. However, increasing age may be associated with increased risk of deep vein thrombosis and pulmonary embolism, and in any case, coexisting conditions increase morbidity, and so there is a need for careful screening. Body mass index, if the BMI is more than 30, there's an increased risk of complication, and both on the donor and recipient sides and partial flap failure. BMI more than 40 is a very high risk of flap failure, so we should be very hesitant to proceed to flap reconstruction. And then again, the problem of the radiation. When do you go for radiation therapy if you need to? Do you do it after? Do you do the flap reconstruction as a delayed reconstruction after irradiation? Do you do the radiation before the mastectomy and then do at the same time reconstruction? Or do you do the reconstruction, mastectomy reconstruction, then irradiate afterwards? And as I told you earlier, it's a major challenge to us. There's no doubt that if you irradiate the flap will produce increased rate of fibrosis. There will be increased risk of complications, and will affect your long-term result of the reconstruction. And also there's the subset of patients presenting for mastectomy following breast conservation therapy with irradiation, which is another major problem starting to appear. And there were reviews showing, again, these problems with the fibrosis, the increased risk of complications if you irradiate the flap. In terms of how do we do these operations, it's two really areas that two set of vessels, the thoracodorsal or the internal mammary vessels. They have similar caliber, artery and vein, but the arterial flow rate on the internal mammary is much better than the thoracodorsal. And there's a small risk of pneumothorax on the internal mammary artery because we remove part of the rib. And the typical description is all started by Hartham, is the different zones of the tram flap as it was described originally, and you doing the pedicle tram flap, which I no longer do that, and I think most of the plastic surgeons wouldn't offer this type of breast reconstruction now. as we would go and do muscle sparing DEP flaps, depending which part of the muscle is removed. You can have muscle sparing 1, muscle sparing 2, or the central part, which is effectively the DEP. And you would put it either on the internal mammary or the thoracodorsal vessels, depending on the length of the pedicle. So there are different options, as well as the S-gap, which is the superior gluteal artery flap, or other perforator flaps, and this is a typical DEP flap on a woman with a ptotic breast, large breast. So LD flaps, these flaps may not provide enough tissue to recreate a breast mount, so are used in combination with a prosthesis or fat transfer, but they are very reliable, and you can do it as extended, and they have a very low failure rate with safe use. And you see that in a patient with recurrence. He had breast conservation therapy for breast cancer on the left side. She had a recurrence 7 years later, so she had LD flap mastectomy, LD flap reconstruction, and another one for bilateral cases. And to conclude, the type of reconstruction varies depending on the patient needs and wishes. Immediate reconstruction, if possible, gives better outcome. Neck-sparing mastectomies are a superior cosmetic result. Irradiation remains a major challenge for the reconstructive surgeon, and the adjunct techniques and use of scaffold and fat grafting have revolutionized the implant-based reconstruction. More focused use of flaps only in the setting of radiation therapy. Thank you very much.
Thank you. That's a great introduction to the next two talks, which are the tips and tricks talks. So we'll move on and then have questions at the end of this part of the session. So the first speaker will tell us about tips and tricks with subpectoral implant-based reconstruction.
So I'm calling Prof. Spiropoulou from the University of Thessaloniki to the podium.
Ήθελα να ζητήσω συγγνώμη γιατί η ενημέρωση μου ήταν ότι η ομιλία θα είναι στα ελληνικά και έχω κάνει την ομιλία στα ελληνικά. Αν θέλετε μπορώ να αφήσω τα slides στα ελληνικά και να μεταφράζω στα αγγλικά. Αλλά θα μας πάρει λίγο χρόνο παραπάνω.
Δεν πειράζει.
Oh, lovely. Ήθελα να ευχαριστήσω την Οργανωτική και την Επιστημονική Επιτροπή του Συνεδρίου και τον κύριο Βενιζέλο προσωπικά για την πρόσκληση να δώσω αυτή την ομιλία. Δεν έχω κάποιο conflict of interest. Τα πλεονεκτήματα μιας υπομυϊκής τοποθέτησης του ενθέματος είναι γνωστά, παρέχει καλύτερη κάλυψη των ορίων και υπάρχει μείωση της ρητίδωσης. Ενώ στα μειονεκτήματα μπορούμε να αναφέρουμε τον περιορισμό στη διαμόρφωση του σχήματος του μαστού και τη μείωση της προβολής και φυσικά το animation deformity που ήδη περιέγραψαν οι προηγούμενοι ομιλητές. Σε μια πλήρη υπομυϊκή τοποθέτηση υπάρχει ένας ρεκνωτικός κάτω πόλος, γιατί δεν επιτρέπεται να γίνει έκπτυξη του κάτω πόλου λόγω της στενής θήκης που υπάρχει, και μια αμβλημένη υπομαζική πτυχή, ενώ μπορεί να παρατηρηθεί και προς τα άνω μετατόπιση του ενθέματος. Σε αυτή την εργασία από το Πανεπιστήμιο Stony Brook, σε μια σύγκριση των αποτελεσμάτων μεταξύ των επιπλοκών σε μη χρήση πλεγμάτων και σε χρήση πλεγμάτων, συγκεκριμένα EDM, παρατηρήθηκαν στατιστικά σημαντικά περισσότερες επιπλοκές σε αυτή τη συστηματική ανασκόπηση, στις περιπτώσεις τις οποίες χρησιμοποιήθηκαν ADM. Παρ' όλα αυτά, σε αυτή την μεταανάλυση του 2018 δεν παρατηρήθηκε αυξημένος κίνδυνος επιπλοκών μεταξύ της χρήσης, στατιστικά σημαντικός μεταξύ της χρήσης και της μη χρήσης πλεγμάτων. Παρ' όλα αυτά, αναφέρονται σε αρκετές εργασίες αύξησης, κυρίως στην φλεγμονή και στο σέρωμα σε περιπτώσεις που χρησιμοποιούνται πλέγματα. Και φυσικά ένα μεγάλο μειονέκτημά τους είναι το κόστος. Στα πλεονεκτήματα μπορούμε να αναφέρουμε τον καλύτερο έλεγχο και καθορισμό της θήκης και της υπομαζικής πτυχής, γιατί αρκετές φορές όταν έχουμε μία παρασκευή της τσέπης, επειδή μπορεί να μας ξεφύγει και να ξεφύγει από την υπομαζική πτυχή η παρασκευή των δαρματικών κρυμνών, μας βοηθάει στο να αποσαφηνίσουμε την υπομαζική πτυχή και μπορεί να γίνει χρειάζεται λιγότερη παρασκευή του μυός και συνήθως παρατηρείται λιγότερη δημιουργία κάψας. Σίγουρα η τοποθέτηση υπό το μείζωνα-θωρακικό είναι πιο οικονομική, γιατί χρειάζεται λιγότερη ποσότητα πλέγματος και παρέχεται μια καλύτερη κάλυψη του άνω πόλου. Υπάρχει ένας κίνδυνος μετανάσκεψης του ενθέματος προς τα άνω, σε περίπτωση που γίνεται τοποθέτηση πάνω από το μείζωνα-θωρακικό, και άλλο σε περίπτωση που τραβηχτούν κάποια ράματα και γίνει αποκόλληση από το μη. Αυτά όμως είναι το αποτέλεσμα, θα είναι το θέμα του επόμενου debate, το οποίο θα παρακολουθήσουμε. Υπάρχουν διάφορα πλέγματα. Αυτά μπορεί να είναι από ανθρώπια προέλευση ή χείρια προέλευση ή βόηα προέλευση, ή επίσης συνθετικά πλέγματα, τα οποία φυσικά είναι αρκετά πιο φτηνά, από απορροφήσιμες ή μη ίνες, όπως είναι το Vicryl, το Tigryl και το Tyloop. Κάποια από αυτά μπορεί να χρειάζονται ενυδάτωση, και οι οδηγίες της ενυδάτωσης είναι από τον κατασκευαστή. Για παράδειγμα, το Alloderm χρειάζεται μια ενυδάτωση από 10 έως 40 λεπτά. Και ενώ το Flex είναι ανθρώπιας προέλευσης και αυτό, και δεν χρειάζεται προηγούμενη ενυδάτωση παρά μόνο έκπληση με φυσιολογικό όρο. Τα συνθετικά πλέγματα, όπως είπαμε, έχουν πολύ χαμηλότερο κόστος από τα μη συνθετικά. Δεν υπάρχει πάρα πολλή βιβλιογραφία σε σχέση με αυτά. Κυρίως το Tyloop χρησιμοποιείται στις πρωτογενείς αποκαταστάσεις με ικανοποιητικά αποτελέσματα, ενώ το Vicryl έχει αναφερθεί με καλά αποτελέσματα σε μη ακτινοβολημένους μαστούς. Ο μέγιστος χρόνος παραμονής ενός ADM στη βιβλιογραφία μέχρι σήμερα είναι 20 χρόνια, ενώ υπάρχουν λίγοι ασθενείς που έχουν παραμονή κάποιο ADM πάνω από 9 χρόνια. Και αυτό είναι ίσως το που μας προδιαθέτει σε μία σύγχυση σε σχετικά με τις ενδείξεις και αντενδείξεις που υπάρχουν στη βιβλιογραφία. Για παράδειγμα, σε αυτή τη μελέτη αναφέρεται η μεγαλομαστία και στις ενδείξεις και στις αντενδείξεις. Και επίσης, η μετεγχειρητική ή προεγχειρητική ακτινοθεραπεία, η μετεγχειρητική αναφέρεται στις ενδείξεις, ενώ η προεγχειρητική στις αντενδείξεις. Βλέπουμε δηλαδή ότι δεν είναι τελείως αποσαφηνισμένη στη βιβλιογραφία η χρήση τους, και κυρίως θα χρειαστεί ακόμη περισσότερος έλεγχος. Στις ενδείξεις αναφέρεται η επέμβαση nipple sparing και η direct to implant, η μη πτωτική μαστή, ένας αδύνατος ημίζων θωρακικός ή με υψηλή έκφυση. Οι Madsen το 2015 περιέγραψαν ότι αυτό μπορεί να συμβεί σε 70% των ασθενών. Και η περίσσια δέρματος, γιατί μας βοηθάει το να βάλουμε πλέγμα και ένθεμα στο να κάνουμε καλύτερη να απορροφηθεί καλύτερα αυτή η περίσσια δέρματος. Στις αντενδείξεις μπορούμε να αναφέρουμε την παχυσαρκία, η οποία διαταράσσει την αιμάτωση, όπως είναι γνωστό, το κάπνισμα, η λεπτή δερματική κρυμνή και η πτωχή αγκίωση για οποιοδήποτε λόγο των δερματικών κρυμνών, παραδείγματος χάρη σε μία αγκιοπάθεια. Θα συμφωνήσουμε σε αυτή την περίπτωση ότι οι ασθενείς με μεγάλους μαστούς είναι σε μεγαλύτερο κίνδυνο για μετεχειρητικές επιπλοκές από ότι γυναίκες με μικρούς μαστούς, και επίσης αυτές οι γυναίκες δεν είναι ίσως και τόσο καλές υποψήφιες για μια τέτοια αποκατάσταση, γιατί δύσκολα μπορούμε να πετύχουμε μια συμμετρία, εκτός εάν κάνουμε αμφωτερόπλευρη υποδωρεά μαστεκτομή και αποκατάσταση. Οι ασθενείς που υποβάλλονται σε αποκατάσταση με διατατήρα EDM ή ένθεμα και EDM έχουν στατιστικά μεγαλύτερο κίνδυνο νέκρωσης και φλεγμονής από ασθενείς τις οποίες γίνεται υπομυϊκή αποκατάσταση, ενώ δεν έχει παρατηρηθεί διαφορά σε σχέση με τον κίνδυνο σερώματος, αιματώματος και εκστροφής. Και πάλι λέω ότι υπάρχουν αντικρουόμενα συμπεράσματα στη βιβλιογραφία. Σε αποκαταστάσεις με χρήση ADM και διατατήρα σε σύγκριση με σκέτο διατατήρα παρατηρούμε ένα πιο φυσιολογικό σχήμα και ένα καλύτερο έλεγχο της υπομαζικής πτυχής, και πάλι υπάρχει δυνατότητα για μια μεγαλύτερη θήκη σε περίπτωση που θέλουμε να κάνουμε αποκατάσταση και του ετερόπλευρου μαστού, δηλαδή μια ετερόπλευρη αυξητική σε μια γυναίκα, για παράδειγμα, που έχει ένα μικρό μαστό και θέλει να κερδίσει κάτι στο μυαλό της από την όλη αυτή διαδικασία, δηλαδή να κάνει μια αμφωτερόπλευρη αυξητική. Υπάρχει δυνατότητα για μεγαλύτερη διαγχειρητική έκπτυξη. Σε αυτή τη μελέτη αναφέρεται ότι σε ένα session κατά μέσο όρο βάζανε 120 ml στη μία περίπτωση που κάνουν αποκατάσταση με διατατήρα και ένθεμα, ενώ στην άλλη περίπτωση μπορούσαν να βάλουν μέχρι 400 ml. Προφανώς αυτό ήταν και για διατατήρες που μένουν μόνιμα. Ενώ η δυνατότητα για επίτευξη του επιθυμητού όγκου ήταν 2 φορές έγχυση σε σύγκριση με 4 φορές έγχυση κατά μέσο όρο. Η βλάβη από ακτινοβολία στο δέρμα του μαστού, η οξεία βλάβη, έχει σαν αποτέλεσμα επιδρά σε μέρες ή εβδομάδες μετά την ακτινοβολία, ενώ η απότερη βλάβη εμφανίζεται μήνες ή χρόνια μετά την ακτινοβολία. Αυτές οι ασθενείς είναι κυρίως υποψήφιες για μια αποκατάσταση με κρυμνό, όπως είπε και ο κύριος Γιαννέας πριν, και αυτό τους προτείνουμε. Παρόλα αυτά, όλο και περισσότερο γίνεται αποκατάσταση στη βιβλιογραφία με χρήση ADM και διατατήρων ή πλεγμάτων και σε ασθενείς με ακτινοβολία. Σε αυτές τις περιπτώσεις κυρίως γίνεται και λιπομεταφορά για βελτίωση της ποιότητας του υπερκείμενου δέρματος και στον πρώτο χρόνο και στο δεύτερο χρόνο. Οι επιπλοκές, επίσης, σε αυτή τη μελέτη έχει παρατηρηθεί ότι σε σχέση με την ακτινοθεραπεία δεν αυξάνονται όταν υπάρχει χρήση του Alloderm από ό,τι υπάρχει όταν υπάρχει μόνο ένθεμα. Παρατηρήθηκε ότι το Alloderm μένει ζωντανό μετά την ακτινοθεραπεία, όταν εστάλει ιστολογική, και η επίπτωση της ερκνοτικής κάψας ήταν το ίδιο χαμηλή στις αποκαταστάσεις με την παρουσία ή απουσία ακτινοθεραπείας. Επίσης, παρατηρήθηκε ότι μπορεί να επιβραδύνει τη δημιουργία κάψας, ίνωσης και ρίκνωσης μετά την ακτινοθεραπεία. Σε αυτή τη μελέτη αναφέρθηκε ότι οι αποκαταστάσεις με tissue expander και ADM ανέχονται καλύτερα την ακτινοθεραπεία από ό,τι αποκαταστάσεις μόνο με tissue expander. Όταν είναι πολικό ένα ADM, αυτό πρέπει να τοποθετείται έτσι ώστε η πορώδης επιφάνεια να έχει επαφή με την καλώς αιματούμενη επιφάνεια, δηλαδή με τους δερματικούς κρυμνούς, ώστε να γίνει από εκεί η επαναγίωση και η ηλία επιφάνεια να είναι προς την πλευρά του ενθέματος. Ένα λάθος στον προσανατολισμό μπορεί να οδηγήσει σε μια φλεγμονώδη αντίδραση που μπορεί να μιμηθεί κυταρίτιδα. Σε αυτή την περίπτωση, το ήθημα εντοπίζεται πάνω από τον κάτω πόλο, χωρίς να υπάρχουν συστηματικά σημεία φλεγμονής και χωρίς ακτινογραφική ένδειξη σερώματος ή αποστήματος. Σε μια προεγχειρητική εκτίμηση, όπως σε κάθε ασθενή που έρχεται για αποκατάσταση μαστού, θα εκτιμήσουμε την πτώση, την προβολή, το μέγεθος του ετερόπλευρου μαστού, τις δραστηριότητες της ασθενούς και την δουλειά που κάνει, την θέση της υπομαζικής πτυχής, τη βάση του μαστού, το αν θα λάβει μετεγχειρητικά ακτινοθεραπεία ή αν έχει λάβει προεγχειρητικά ακτινοθεραπεία, το μέγεθος του ετερόπλευρου μαστού και αν θέλει να παρέμβουμε σε αυτό και αν έχει περίσσια λίπους σε κάποια σημεία του σώματος που μπορούμε να τα χρησιμοποιήσουμε για να διορθώσουμε το περίγραμμα. Παρασκευάζουμε το μείζωνα θωρακικό από την 4η έως την 8η ώρα και μπορεί να γίνει έλεγχος των δερματικών κρυμνών αν υπάρχει δυνατότητα με χρήση ινδοκιανίνης. Αν δεν υπάρχει δυνατότητα, θα καταφύγουμε στην κλασική κλινική παρατήρηση, όπου θα δούμε εάν ματώνουν καλά οι δερματικοί κρυμνοί μας και φυσικά αυτό έχει σχέση και με την συνεργασία του χειρουργού μαστού με τον πλαστικό χειρουργό. Εν συνεχεία, μπορούμε να τοποθετήσουμε ένα sizer, το οποίο θα έχουμε κάνει μια προεγχειρητική εκτίμηση και να κάνουμε μια προσωρινή σύγκληση με stapler για να δούμε πώς κάθεται το ένθεμα που έχουμε επιλέξει και να διορθώσουμε τα αυτιά και επίσης και πάλι αν υπάρχει δυνατότητα να χρησιμοποιηθεί η ενδοκιανίνη για να δούμε σε αυτή την περίπτωση εάν με το φούσκωμα του sizer επηρεάζεται η αιμάτωση των δερματικών κρυμνών. Όπως βλέπουμε, οι δερματικοί κρυμνοί όταν δεν έχουν καλή αιμάτωση αυτό φαίνεται πιο σκούρο και όταν έχουν μια καλή αιμάτωση φαίνεται να φωτίζει. Και αυτή η περιοχή που δεν έχει καλή αιμάτωση μπορεί να αφαιρεθεί σε πρώτο χρόνο ώστε να μην δημιουργηθούν προβλήματα σε δεύτερο χρόνο τα οποία θα είναι δυσεπίλητα. Εν συνεχεία, μπορούμε να εκπλύνουμε τη θήκη με αντιβιωτικό διάλειμμα, το οποίο στη βιβλιογραφία περιγράφεται σαν διάλειμμα βακιτρακίνης, γενταμικίνης ή κεφαζολίνης. Εμείς χρησιμοποιούμε μόνο μπεταντίν. Κάνουμε διαβροχή του πλέγματος εάν χρειάζεται και το μουσκεύουμε εάν δεν είναι pre-hydrated με φυσιολογικό ορό ή διαφορά κάνουμε μόνο έκπληση και χρησιμοποιούμε ένα πλέγμα το οποίο να έχει εύρος 8 εκατοστά κατά πάσα πιθανότητα, εκτός από πολύ μικρούς μαστούς που μπορούμε να χρησιμοποιήσουμε 6 εκατοστά εύρος, γιατί δεν μπορούμε να επιτύχουμε διαφορετικά μια καλή πτώση και ένα καλό redraping του μαστού. Εν συνεχεία, σειράπτουμε το πλέγμα με ένα συνεχόμενο PDS, βραδίας απορρόφησης ράμα, κατά πάσα πιθανότητα με στρογγυλή βελόνα, γιατί ένα ράμα με κόπτουσα βελόνα μπορεί να σκίσει το μη όταν βάζουμε τη σειραφή μας. Και κάνουμε βήματα ανά 1 εκατοστό, έτσι ώστε να έχουμε ένα καλό έλεγχο των πτυχώσεων και μια υδατοστηγή σύγκληση. Εν συνεχεία, αφού βάλουμε στον κάτω πόλο, μπορούμε να ράψουμε στον άνω πόλο το πλέγμα μας και να δούμε πώς κάθεται μέσα σε αυτή την τσέπη το ένθεμα, ή μπορούμε να το κάνουμε και ανάστροφα, δηλαδή από το να ράψουμε όλο συνεχόμενο στο μείζωνα θωρακικό και μετά να το φέρουμε κάτω για να δούμε πώς μας κάθεται καλύτερα. Συνήθως οι περισσότεροι προτιμούν την πρώτη επιλογή. Θα τοποθετήσουμε παροχετεύσεις και πάνω και κάτω από το πλέγμα, με βάση τη βιβλιογραφία, και είναι καλό να τις αφήσουμε αρκετό χρόνο, περισσότερο από θα τις αφήναμε σε άλλες περιπτώσεις, γιατί, όπως είπαμε, το σέρωμα είναι μια συχνή επιπλοκή. Αυτό που περιγράφεται είναι να αφαιρέσουμε τις παροχετεύσεις αν δεν δίνουν λιγότερα από 30 κυβικά εκατοστά, η οποία είναι η απορροφητική ιδιότητα του οργανισμού μας για 3 συνεχόμενες ημέρες περίπου. Πρακτικά αυτό σημαίνει την 7η-10η μετεγχειρητική ημέρα. Παράταση του χρόνου της τοποθέτησης των παροχετεύσεων θα υπάρξει σε περίπτωση ακτινοθεραπείας, αυξημένου δείκτη μάζας σώματος, μεγάλου μεγέθους διατατήρα. Ενδεικτικά να φέρουμε κάποια περιστατικά. Σίγουρα θα έχουμε ένα καλύτερο αποτέλεσμα σε μια αμφωτερόπλευρη αποκατάσταση, σε μια αδύνατη ασθενή και που δεν έχουμε από κάπου αλλού να πάρουμε. Επίσης, αυτή η ασθενής μας ήρθε μετά από κάποια αποκατάσταση που έκανε αλλού και κάνουμε μια συμμετρικοποίηση και πάλι με ένα πλέγμα και ένθεμα και μια τομή τύπου TAF στη μαστεκτομή. Και σε αυτή την ασθενή κάναμε μια αποκατάσταση με πλέγμα και ένθεμα με τον φίλο μου τον Θοδωρή στη Θεσσαλονίκη. Ευχαριστώ πάρα πολύ.
Thank you so much. I think we'll reserve the questions for the end. Thank you. So we're going to move to the prepectoral area now. And last but not least, Mr. Peter Barre, who is a consultant breast and oncoplastic surgeon at the Royal Marsden, will talk about this.
Θέλω να ευχαριστήσω Μιχάλη και τους διοργανωτές για την τιμή να βρισκόμαι μαζί σας σε αυτό το καταπληκτικό συνέδριο. Σας ευχαριστώ από καρδιάς.
Peter, sorry. You're supposed to give the talk in Greek.
I must say, I did panic. I'm panicking about the debate. I have to Google translate it very quickly in the break. Okay, so. Okay. I'm not sure that I understood too much of the last talk, but we'll see how we go. I'm going to give you really some tips and tricks. This is very low-level stuff on my experience and what works for me. It won't necessarily work for everyone. And I'm going to talk about the preoperative aspects, intraoperative and post-operative aspects. This is, of course, our beautiful venue. I can't believe we are here. It's really a great privilege. I'm going to warn you, though, that this talk is going to be a low data mode, okay? Χωρίς βιβλιογραφία. So, the first thing is, can we reduce the need for mastectomy? And I think others have already spoken about this, but really the question is, does the patient need a mastectomy? Can we use advanced oncoplastic techniques to avoid the problem in the first place? And again, from my personal experience, I can tell you I've reduced my complication rate with prepectoral reconstruction by doing less of them. So I'll admit, I'm the first one to admit that. The next thing is really careful patient selection. And I think we can class local and systemic factors. I think smoking and vaping comes under both. We'll talk about this a bit more in the debate. Skin and tissue quality needs to be assessed. The degree of ptosis. Do we need to do skin reduction? And can we keep the nipple areolar complex? And then what's the availability of fat? Because in prepectoral, this is a very important question due to the possibility of rippling down the track. So we need to look into systemic factors, medications, immunosuppression, uncontrolled diabetes, and other systemic problems. And of course, we've mentioned smoking, of course. And oncological factors are very important. So what's the biology of the disease, but also the extent, very importantly, carefully assessed for locally advanced disease. Skin and muscle involvement is very important. And again, the NAC, the nipple areolar complex. And really review the imaging very carefully. And the other thing, of course, is the axilla and what's the extent of axillary disease and treatment required. because these may all impact your post-operative recovery. And then finally, the treatment effects. What's coming next? So first of all, are there issues from systemic therapy that's already been given, cardiac issues, for example? Neoadjuvant chemotherapy can play a role in complications. And then is radiotherapy required post-operatively? And we've heard a lot about radiotherapy in the last talk. Obviously, it's a big challenge for us all. And finally, if you're going to do a bilateral case, and there's good data now from the UK from a large prospective cohort, that if you can minimize the duration of the operation with implant surgery, you can reduce the infection complications. And so get a trusted colleague on board. I happen to have a trusted colleague in the first row of the audience, and we'll see her hands later. But really, it's very important. Let's halve the operative time. And this can be difficult, challenging in different settings, the private setting versus the university hospital setting. But I think we need to argue the point, and I think there's going to be more literature about this. There already is literature with 2 surgeons in other fields. So the first question is, do we select single stage or 2-stage? And we've heard a bit about this now. There's a very elegant paper, and if you haven't familiarized yourself with it, I would, by Alberto Rancati from Argentina. And he and the surgeons from Milan, and Italy in general, looked at the digital mammography and classified patients as having more than 2 centimeters, 1 to 2 centimeters, or less than 1 centimeter of subcutaneous fat around the breast parenchyma. And especially useful for patients with very dense parenchyma, clearly, because you can see here, and it may not reflect exactly what you find at surgery, but it gives you some idea going into the operation, before you plan the operation, how much subcutaneous fat you can expect. And here's an example of a patient of mine. She's a BRCA2 carrier, and you can see that I'm somewhat gratified by the fact, and the MRI is at the end there, by the way, digital mammography and MRI, that she at least has some degree of fat beyond the nipple areolar complex, and that I'm going to likely succeed with a single stage. I always prepare with expanders, but I think this is a case of single stage, whereas this lady, who's actually smaller breasted and a bit tubular as well, has also clinically, but also on MRI, features suggesting that the skin may be very thin in certain areas, even peripherally. And for this lady, I would plan an expander and 2-stage. So then let's go to the operating theatre and the markup. I mark the patient standing up, and I find that for patients who have a bit more breast tissue, to mark the lateral fold, I raise the arms. And I plan, my standard incision is a meridian, starts at the meridian at the nipple level and goes laterally, so basically 6 o'clock to laterally. I mark where the cancer is, as well as the incision, because where is the cancer most superficial? Because I really need to focus carefully there to get a good anterior margin on this. And that's very, very critical. And then for a skin reduction patient with significant ptosis, I need to then design some form of reduction pattern. And whilst the WISE pattern is probably the one we all know, there are other patterns, including circumferential, like almost like a round block in a way, but also circumtransverse is very good. And the other thing is I do this infralateral IMF incision as a standard because there is some good data, again, from Rancati's group, that some of the nerves where the ACAP vessels are, the anterior inferior artery, there are nerves to the nipple arising from that meridian. And so if we can stay lateral to that, we may spare some of the sensation to the nipple. Okay, so I use a closed technique, and I think the key to this, and I'll declare now a conflict, I don't have a SPY device. I never have, and probably never will where I work. But the point is that I use a closed technique, so there's minimal retraction on the skin envelope. And I tumesce the patient, so I infiltrate saline and adrenaline, or Hartmann's and adrenaline. And I use this standard fat transfer needle, which you probably recognize. It's a 1.5 millimeter, but it's got a round tip. So rather than a sharp dissection, it's a blunt dissection, and it tends to find the right plane that we need to dissect. So it tends to work very well. And then my next little tip is that I deepithelialize the incision first. So I do a little crescent, and I deepithelialize, and what I do is my incisions will be at the caudad end, so that I have this dermal shelf protecting against the retraction to minimize damage to the skin. because if I can minimize wound trauma and healing delays, then I can minimize the risk of secondary infection from that. This is Dr. Constantinu's hand on the other side. You can see she's doing some things there. So, I don't do this alone, just to emphasize that. There's a little incision in the skin you'll see for that needle for the infiltration. I often do it at the upper inner edge of the areola to get to the upper inner part of the breast. So that's one of my other little secrets. So I use blade or scissors. I personally don't use diathermy on the skin flap. That's just my personal policy. I think I've had a lucky run, and I won't go to diathermy because I just don't trust myself with it. And when I train others, I think they should learn a technique that doesn't involve diathermy. Now, I have no experience with the plasma blade, and people who use it swear that it's very, very good. But anyway, let's go back to basics. So there's this particular Gorney-Freeman scissors that's actually a facelift scissor, slightly curved, and it's very nice. It's almost like a blunt dissection, really. It finds the plane well, and I tend to use a 10 blade. And through these, you can see there's 3 little incisions I've made that I showed in the last slide, 3 little incisions, full thickness, and I just, in arc-like motions, I use the blade or scissors to undermine the skin, advancing in small arcs and then advancing step by step until the whole breast is done. I stop short medially to avoid perforated damage. And of course, peripherally, I just stop before the lines. It's very important to mark the breast initially because the tumescence tends to distort everything, and the patient looks like they've had a breast augmentation on the table. So again, this is my trusted colleague doing the same on the other side. Now, this patient interestingly had a rectus sternalis muscle, but you can see once we've done the superficial dissection here, you can't see that. I then go deep prepectorally. And the big mistake a lot of trainees make is they go too deep and they end up under the pec major. I go onto the pec major and dissect this freely, and then the periphery. And the important thing is to keep a snug pockets, really hug the breast. Don't veer away from the edge. Medially, watch the perforators. Laterally, avoid the posterior space. And then supramedially, it's never a straight line. It's always tongues of tissue going up and down. So check for completeness. I always get my trainees, I do it after my fellows too. I just swipe the hand down the chest to see that there's no bumps, because that indicates residual breast tissue. When you know the recurrences occur in that supramedial aspect where it's difficult to reach with these inferior incisions. So we're very, very careful about that. And we try and preserve the IMF. For the mastectomy flap, bipolar hemostasis. Now, at this stage, I do the PECs 1 and 2 blocks, either under ultrasound or under direct vision, of course, because we are there. I do it at the end of the mastectomy because I want it to last longer, just before the implant goes in. So what about ADM? We've heard quite a bit about ADM, I think. I use an anterior cover only because I think it's cheaper and I want less material. I don't need posterior cover. And you can extend it using a serratus fascia flap in that infralateral angle. And I'm not sure what it really does, to be honest. I think in some cases it stabilizes the pocket, but we don't use it in everyone. We are selective. And if you look at the ADM price, this is real estate in the UK, and I'm horrified to see that Athens is approaching these prices, but this is the price of the top price in London. This is about 5 years ago, 20,000 per square metre. Well, ADM is this much per square metre, 110 to 140,000 per square metre. So it's very expensive. I recommend that you buy some land somewhere in Greece for £40 a square metre and grow some pigs or lambs and make ADM. That would be a very good enterprise for anyone who's entrepreneurial out there. So this is the end. You can see that the incision has no burns or anything, and I find it easier to do the deepthalization at the beginning, not repair the wound at the end. I find it difficult. I'm tired by then, and it's always difficult, I find, to do that. So negative pressure dressing I use selectively for high-risk patients, such as those that have already had radiotherapy. And yes, this is a disaster we won't talk about. And then I'm going to go into the immediate post-operative period, time permitting. What happens in recovery? The dressings you've seen, usually brown tape and clear dressings for the wounds. I continue antibiotics at least until the drains are out, and there's reasonable evidence to suggest that that's a good thing. And then I use a nitrate patch or ointment. You can use the low-dose ointment, on the nipple, which has been shown in some studies, not the best quality studies, to improve blood supply and reduce necrosis, certainly full thickness. Usually I say one for each nipple and one for me after the operation. And then, of course, I don't use bras initially in the first week, but after the tapes come off, then I use bras. So this is what it looks like. The patient looks like this usually. This was my fellow's side. This was my side. I've got the one with the superficial nipple necrosis, which is now healed, thankfully. And, of course, I justify this by saying I took all the ducts, you didn't. You know, you need to do a better job next time. So that's how it looks. And this is a patient that you'll see. And there's a little bit of rippling here. This is pre-op and this is post-op. It's this breast, of course. Okay. So there's a 14-point plan that the plastic surgeons will be very familiar with that Diva wrote about in relation to ALCL, actually, in preventing implant infection. I've modified it for my use. And first of all, I stop entry into the theatre. We have signs, do not come in. If you have laminar flow, that's great. Obviously, intravenous antibiotics on induction. I don't use nipple shields. What I do is when I've finished the pocket dissection, I put betadine under the areola because I figure the bugs are going to be inside and they're the ones I'm worried about. We then change instruments and drapes. It's like changing personality, really. Then the plastic surgeon walks in, my alter ego. We then use a sleeve always, and this can be a glove, a surgical glove. It doesn't have to be a color funnel. But when you put the implant through the incision, you don't want it to contact the skin because that's how biofilm starts. It's that trauma of moving it through the skin, especially if it's textured, even nano-textured. You want to use some protective device. Minimize the implant exposure to the air. So I favor, as you saw, parachuting the ADM when I use it in and then putting the implant in and covering the whole thing. I don't do it on the table because that exposes the implant more, but you know, I think people do it very well. And just minimize handling of the implant. Now, I use a drain, of course, but I also use antibiotic ointment at the drain site, and there's a very good randomized controlled trial done by Judy Bowie at the Mayo Clinic using a Chlorhex disc showing reduced contamination of the drain. So I think that's an important little tip. And I think all these things little steps can add up to a better result. I won't go through the surgical technique again. What about post-op? What do we do to prevent things going wrong? And so post-discharge, again, oral antibiotics. I advise about thermal trauma because it's very important. Most of the breast is insensate, including the nipple areola, and you don't want patients putting on warm packs, ice packs, all sorts of things that can cause full-thickness burns, and this has happened in various places. Very close communication with the patient, and where I work, and it's very much context-dependent. It depends where you work, what the system is. At the Marsden, you might think it's paradise because we don't have an accident and emergency department. We don't have emergency. But the question is then, where do the patients go when they have an emergency? And that's the problem I learned very quickly when I started there. And so what I do is I get them to message me every day on WhatsApp, the drainage amounts. So I know how much is in the drain and when the drain can come out. And then I tell them to tell me about any signs that they might have infection. And we do have a hotline, but it doesn't really work in this instance. So this is an example of good communication. You can see morning drain is 40 today, blah, 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 blah. And this is my reply, usually one line, no problem, keep in touch. Oh, great, 80 mils in both drains. And then this is what happens when things start to get a bit hairy. So this is a picture of their drain, the wound, red breast syndrome. And you can see it's a very quick way of communicating. And, this is, if you look down here, I would say, please come in now. Okay. So it's a way that you can get an early warning system and then they can come in and see the team or see me and sort things out. Because I think this is the one situation where you need to respond early. I'm going to leave it at that because I've run out of time. But I think
would give you a few more minutes if you want to go on.
Okay. In Greek. So early review, red breast syndrome, usually weeks 2 to 4, and it's almost always due to ADM. So this is something to be aware of, ADM. In the prepectoral, it's very unforgiving, and you can get even problems later with the nipple areola complex with superficial necrosis. So you've got to be a bit careful, and you need to watch it probably for up to 6 weeks. This is red breast syndrome, typical red breast syndrome. The clue is the patient has feeling in the décolleté, and they're often itchy here. They can't feel the rest, but this is itchy, and that's a big clue, and it usually comes on 2 to 4 weeks. It starts with petechial rash and then becomes confluent. This is one of the worst cases I've seen. The treatment is usually topical steroids and antihistamines. Occasionally systemic steroids are needed, and it always self-limits. If you are brave, you don't use antibiotics, but if you're not sure, obviously, antibiotic cover, and this was about a week later. So the next big thing really is tissue loss and superficial infection. Again, if it's partial loss, you can manage this conservatively. If it's full thickness, though, and you want to prevent it becoming full thickness if possible, then you need to go to surgery, or if there's peri-implant infection. So assess tissue perfusion, and how do we reduce the possibility that there may be full thickness necrosis? I think if there's a seroma, aspirate it, take the pressure off as soon as you suspect problems. If there's an expander, deflate it. And finally, negative pressure dressings are very good for partial thickness. And if you're in doubt, then debride early or examine the tissue early to see if they do need to go to theatre and be debrided. Just an example, seroma aspiration on MRI. I don't know why she had an MRI, but there's a posterior seroma here. She liked the cleavage, but there you go. And then we do imaging, maybe an ultrasound aspiration. CRP is much more sensitive than the white cell count. That's a C-reactive protein. And any swabs, antibiotics, and then close review. But within 48 hours, we operate on if they're on IV antibiotics. If there's no cellulitis, we wash out, we replace the implant, put a drain in, and an irrigation catheter and intravenous antibiotics. And usually you get away with it in about 80% of patients. But if there's cellulitis already and there's pus in the cavity, then the negative pressure wound therapy system is very useful and will potentially save your patient from becoming flat. But you need to reoperate and you need to talk to the patient. And finally, this is another option, local flaps from below, where you can put a flap with skin to salvage. And this is a lady who'd had whole body radiotherapy, and we did an ACAP flap to salvage her when she had a problem. So I do get problems. And the worst case, of course, is to decide to remove the implant for sepsis, or if there's significant comorbidity, or if you're waiting on adjuvant therapy. Oncology should always trump any other issues, and the patient psychology can be a big problem here too. So support and motivate the patient. And if you're inspired to continue, you can usually succeed with all problems. Thank you.
Thank you, Peter, for this talk. Any questions from the audience? Let me start. Thank you, first of all, for describing us or giving us tips and tricks for the correct mastectomy, because I think a good reconstruction, prepectoral or under the muscle, starts with a good mastectomy. And I liked when you said that when you go up and medially, you take care. You're very careful with the vessels going into the breast anyway. Because the topic, this topic was about prepectoral reconstruction, I want to ask you, is there any case, I know that you're a big fan, supporter of prepec reconstruction, is there any case that you will say, this patient is not good for prepectoral, I would rather put it under the muscle? Any case? Radiotherapy, we used to often say that radiotherapy is a contraindication, perhaps.
Can I maybe invite you at 2 o'clock for a debate?
Okay.
Is the simple answer to the question. Look, I think there potentially could be, but I've not found one yet, to be very honest. The debate is a good title because it says hardly ever. Look, there probably are, but let's hear what the other speaker will say in the debate. Let's say that.
Any questions from the audience?
Thank you for the nice talk. Can I ask you, what's the risk of rippling on the prepectoral? And do you have a number?
Yeah, look, I think, it's interesting. Early on, if you look at, so first of all, the first 6-8 weeks, patients are super happy because there's edema. And then the edema settles and they say, what's this? You know, and you say, remember, I told you. So look, about 40% of patients get rippling if they're low BMI. So again, prepectoral is very good in high BMI or with the breasts I showed you with that very thick flap or thicker flap, because then they get good padding. But all patients probably get a little bit of rippling, and especially in the cleavage. And often it's when they tell you, they lean forward and the implant falls off a little bit, and then they get this rippling. And in fact, you can see it in women normally without implants sometimes, if you look. So, yeah, I tell them about 40% will get it. I tell them often it settles with time, because it does actually settle with time. With radiotherapy, it gets better because they get increased skin edema chronically, and possibly due to capsular contracture, the skin stretches a bit, so it's better. But there are about probably 10 to 15% of patients who it persists, and we do fat grafting. And that's why I always check what their fat reserves are like when we do this operation, and I warn them if they don't really have fat at all, that this could be a problem.
Do you do the fat grafting, or you refer them to plastic surgeons?
I do it most of the time, but if it's, for example, just lumbar fat or some difficult areas like the inner thighs, then I'll refer it to my Greek plastic surgeon colleague.
Any questions for Mr. Barry or for the previous presenters, τον κύριο Γιαννά, την κυρία Σπυροπούλου? Any questions? Yes, Dimitris.
I would like to ask. Yes, I would like to ask Mr. Barry. Let's say that you have made a two-stage reconstruction. You have put the expander, the tissue expander, inside, and some weeks later, seroma develops, and you aspirate, all right, but it keeps coming again back. You make the second aspiration. There is no signs of infection or anything. What will you do in such a case? You will remove the tissue expander, remove the capsule. What you will do?
Well, actually, you mentioned tissue expander in two-stage specifically. So in this situation, I aspirate the seroma and inflate the tissue expander, because to increase the pressure will reduce the dead space for the seroma to accumulate. So this is one way to generally eliminate it. If they're waiting for radiotherapy, then you want this to settle quickly. I think I would wait probably about 6 weeks for this to settle, and if it doesn't settle, then put a small drain in percutaneously in the clinic in an aseptic sort of fashion, and then leave a drain in for a few weeks until it settles. But usually if you really expand the expander fully, then it tends to settle.
So thank you very much. I think we're good with time. Thank you, Peter. Thank you so much. And ευχαριστώ όλους τους ομιλητές για τις ομιλίες σήμερα. Η ώρα είναι